Retrograde intrarenal surgery. 51-year-old female patient with 2 left renal stones, one in the renal pelvis and the other in the lower calyx. The preoperative non-contrast CT on abdomen and pelvis, showing 2 left renal stones, one in the renal pelvis measuring 20 mm by 17 mm, and the other smaller one is in the lower calyx. The density of the stones is 1100 Hounsfield units. The patient is positioned in lithotomy position, then the safety guide wire is fixed. Introducing the semi-rigid ureteroscopy to evaluate the ureter, passively dilate the ureter and fix the second guide wire. The flexible and navigable access sheath is introduced gently over the second guide wire and under fluoroscopy. Removing the trocar of the access sheath. Introduction of the flexible ureteroscope via the access sheath. Reaching the stone in the renal pelvis and starting stone disintegration. Your plan is to dust, not to fragment the stone. Dusting of the stone depends on laser settings and the way that the laser touching the stone. To avoid thermal injury of the laser, the total power should not exceed 35 watts and it's preferred to be around 25 watts. High frequency is important during dusting, and you can adjust the energy according to the hardness of the stone and according to your preference. Also, using the long pulse width is important to reduce the retropulsion of the stone. For dusting the stone, there are 2 techniques, either painting or chipping. Painting is to place the laser fiber in contact with the stone, brush back and forth across the stone, ablating layer by layer. Chipping is to place the laser fiber in contact with the edge of the stone, leaving chips less than 1 mm. Chipping is a good option for a hard and large stone to save the time. You are controlling the laser fiber movement by macro rotation and micro rotation. Macro rotation means rotation of the scope with the dominant hand for broad navigation. Micro rotation means rotation of the scope by the non-dominant hand, either at the urethral meatus or at the entrance of the scope into the access sheath. Micro-rotation is used for fine movements. After complete disintegration of the stone, extract the residual small fragments by using the suction sheath. Final scanning for any sizable residual fragments resulting from disintegration of the large stone of the renal pelvis. Finally, scanning for the other stone in the lower calyx. If the angle of deflection is acute, the manipulation will be difficult. Therefore, the stone will be located to another calyx by using zero-tip basket. Dusting of the stone is subsequently carried out in the middle calyx. Finally, fixation of double J stents under fluoroscopy